And at this time, Dr. Duffs, as the representative of the Center for Disease Control and Prevention's National Office for HIV, STT, hepatitis, and tuberculosis, he will now give his keynote address.
So, good afternoon. So I have the unenviable task of finishing up. I'm the only thing standing between you and lunch. And I know what that's all about. So I'm going to try to not only educate you, but also entertain you. And I'll keep talking until I get the stop signal, right? Wherever I am, whatever it is, it's going to be important. I should also add that this is so emotional for me because it's like coming back home. I'm Jamaican by birth. And so Brooklyn has a lot of Jamaicans, a lot of Caribbean people. And I also went to Brooklyn College. So it's really coming back full circle. So the invitation here is very much appreciated, and I try not to cry, but thank you for what you do, and it means so much to me. Thank you. All right, so I'm going to talk about how social determinants of health impact health outcomes, health disparities in communicable diseases, HIV, viral hepatitis, STD, and TB, and talk about reducing health disparities and promoting health equity. And so I think it's important to go over the definitions, since I want to be sure that we're all on the same page and we know we're talking about the same things. And so health disparities are differences in the incidence, which is new cases, prevalence is new and old, of health conditions and health status between groups. So disparities are numbers. Not all disparities are unfair. Then there are health inequities, which is the systematic and unjust distribution of social, economic, and environmental conditions needed for health. So for example, unequal access to quality education, healthcare, housing, and so on. In contrast, the health equity, which is the opportunity for everyone to attain his or her full health potential. No one is disadvantaged from achieving this potential because of his or her social position or other social determined circumstances. And here we talk about social determinants of health. Those are the life-enhancing resources whose distribution across populations effectively determines length and quality of life. So food supply, housing, and so on. So simply put, if you have 3 children, different ages, they're all different height, and you decide to take them to a baseball game, and you decide to give them all the same stool. At the end of the day, if they all get the same stool, you end up at the same place. Some can see and some can't. So you really never want to ask for equality. You want to ask for equity. Equity is based on proportional need. If you need more to get to wherever the defined point is, you get more. If you need less, fewer, you get less, right? So always ask for equity. That's where we'll all be at the same level, not equality. So the World Health Organization has a social determinants of health model to understand HIV inequalities, which could be applied to any disease. And you can see some of them here: education, occupation, income, gender, psychosocial factors, behaviors, biologic factors in the healthcare system. I'm going to go through in this presentation some of them, and you've heard a couple of them mentioned. But for the diseases of my center, NCHH, SDP, there's some additional ones that we've put in. So HIV, STI prevalence in your community. So you could be a good girl or a good boy, but because the disease prevalence is so high in your community, you're likely to encounter someone who has the problem and gives it to you. The correctional system is funded for security, not for healthcare. There are more people in corrections proportionally who have higher rates of substance abuse and mental health. They're not a hospital. You're not going to go there for healthcare, even though the health conditions are overrepresented there. We know about migration status. If you're an illegal immigrant, a problem to get in health services. So it's not just America, to be fair. In race-conscious societies such as the ones listed here, the non-dominant racial groups have worse health than the dominant racial group. So let's look at life expectancy for indigenous women. In New Zealand, and these are the indigenous populations here. In New Zealand, life expectancy is 81 in 2004. For everyone else, for the indigenous population, 73 years. In the United States, for whites, it's 80 years. For the indigenous population, it's 74 years, a gap of 6 years. Do people think this is a big number? All right, don't answer yet. I'm going to show you what it is. Let's look at infant mortality by race. And this is the odds rates for death And here for blacks, for coloreds, that's what this is called, mixed race in South Africa, Asians and white. For if you're colored, you're 30% less likely to die as an infant compared to blacks. If you're Asian, you're 40% less likely to die as an infant. And if you're white, you're 80% less likely to die compared to a black infant in South Africa. Race and health, there are two patterns. Racial groups with a long history characterized by economic exploitation, social stigmatization, and geographic marginalization have markedly elevated levels of poor health outcomes. Also, immigrant groups, and this is important to me since I'm one of them, immigrant groups tend to have better health than the US average, but their health tends to worsen over time and across subsequent generations. So let's look at lifetime prevalence of psychiatric disorder as an example of this by race and generational status. For Caribbean Black, Latino, and Asian. First generation, so like myself. Second generation, my children. Third generation, my children's children. If you notice that the prevalence of psychiatric disorder increases across subsequent generations for Caribbean Black. The same for Latino, and even the same for Asian. It appears there's something about living in America that drives us crazy. So let's look at life expectancy. So people are living longer. No matter how much we criticize our hospitals and our hospital systems, people have lived longer. If you look at whites, for example, in 1950, the average lifespan here was like 69.1 years. If you look in 2010, it's now 78, 79 years for whites. Same for blacks. In 1950, it was like 61 years. And in 2010, it's now 75 years. It's a gap of about 4 years. Is that a big difference? Show me a raise of hands if you think that's a big difference, if 4 years is a big difference. It's a huge difference. You know why? Because the last time with whites were 75 years life expectancy was 1980. 30 years. It took 30 years to close that gap. All right? So even a 4-year difference is a humongous difference. It took a generation to get to that point. So there are large racial ethnic differences in socioeconomic status. Higher income, longer life. Ask for more money. Adult life expectancy increases with increasing income. Men and women in the highest income group can expect to live 6.5 years longer than poor men and poor women. Ask for a raise. All right? Even if you're within a racial ethnic category, a rich black person lives longer than a poor black person. A rich white person lives longer than a poor white person. Ask for money. So if that's true, let's look at median household income by race in 2013. Racial differences in income are substantial. For every dollar a white person makes, Asian makes $1.15. Hispanics make 70 cents, and blacks make 59 cents. So if income correlates with health, right away, you see a problem. Now let's look at wealth, everything that you own. So for every dollar of wealth that whites have, Asians have 81 cents. Blacks, you have 6 cents. Latinos, you have 7 cents. I just told you that income and wealth is important for health outcomes. That's a problem right here. So racial ethnic disparities in health is more than socioeconomic status. We think everyone is going to college. Not true. Everyone here might have, right? But for the United States, for whites, according to Census 2010, only about 31% of whites. Blacks, 18%, Asians, 50%, Hispanic, any 13%, Pacific Islanders, 15%, American Indian, Native Alaskan, 13%. Not everyone is getting education. And I'm telling you that education is important to have a good health outcome. So more education means longer life. For both men and women, college graduates can expect to live at least 5 years longer than individuals who did not finish high school. So if you have any educational thing pending, go do it. All right? That's the second lesson. So life expectancy at age 25. How long do you think you're likely to live past 25? So for all, we know that there are black-white differences, that there's a gap. White individuals live longer than black individuals. We know that. I just showed you about life expectancy, right? I also told you that education is important. So even within racial groups, if you're white and you have education between 0 to 12 years, you're going to live a shorter period than someone who's white, who's a college grad, a difference of about 6 years. Ask for money and get an education. The same if you're black. If you have 0 to 12 years of education, you expect to live 47 years, predicted at age 25. And if you have a college degree, 52 years, a difference of 5 years within that group. All right? But notice something, that if you're black and have a comparable educational level as someone white, you are expected to live a shorter period. You're essentially not equal in terms of your health outcomes, which suggests that there's something else going on besides education and income. So I'm a doctor, and I figure, hey, I have a lot of school. I mean, half my life seems to have been in school. So maybe I'm gonna live forever, I hope. So there was a study where they looked at a cohort of Meharry Medical College graduates who graduated between 1958 and 1965, and compared that with a white cohort from Johns Hopkins. 23 to 25 years later, to look at differences. Doctors who went to a historical black college and doctors who went to Johns Hopkins, who were white. The black doctors had higher risk of cardiovascular disease, earlier onset of disease, incidence rates of diabetes and hypertension that were twice as high, higher incidence of coronary artery disease, and higher case fatality rate, even among a highly educated population. Why does race still matter? Could racism be a critical missing piece of the puzzle to understand the pattern of racial disparities in health? Despite enormous progress in race, there are ubiquitous signs of the pervasiveness of racism in our culture. There is something called individuation, and now patients will tell you this. When the patient walks into the room, we just label them, right? There they go again, that drug user, that welfare recipient, that this, that. Instead of looking at across populations and treat each person as an individual, right? And then the patient never comes back to the doctor's office, and we wonder, why won't they come back? We blame the patient and not the image we put forward. So there's institutional discrimination can restrict socioeconomic attainment and group differences. Segregation can create pathogenic residential conditions. Discrimination can lead to reduced access to desirable goods and services. Internalized racism, the acceptance of society's negative characterization, can adversely affect health. Racism can create conditions that increase exposure to traditional stressors, and experiences of discrimination may be a neglected psychosocial stressor. So residential segregation, where you live, matters. Geographic location determines exposure to risk factors and resources that affect health. So it's not everywhere in Brooklyn has a problem, right? You know the communities, right? It's not everywhere in New York City has a problem. It's certain neighborhoods. And guess who lives in those neighborhoods? So residential segregation is a place-based example of institutional discrimination that has pervasive adverse effects on health. So racial segregation is basic to understanding racial inequality in America. It's key to understanding racial inequality. It's the linchpin of US race relations and the source of the large and growing racial inequality in socioeconomic status. It is one of the most successful political ideologies of the last century and a dominant system of racial regulation and control, and is the key structural factor for the perpetuation of black poverty in the US and the missing link in the efforts to understand urban poverty. So how does segregation affect health? It determines the quality of education and employment opportunities. How many hospitals are there in Brooklyn compared to Manhattan? Segregation can create pathogenic neighborhood and housing conditions. How many luxury high-rise condos there are in Brooklyn? Conditions linked to segregation can constrain the practice of health behaviors and encourage unhealthy ones. We say to someone, you should get 30 minutes of exercise every day or 3 times a week. We're the jogging path, right? Or if you go jogging, is a car gonna run over you? Or if you're in South Carolina, maybe you get shot, right? Running through that park, right? Segregation can adversely affect access to high-quality medical care. If you live in a community where there's no hospitals, you can't get care. In the 171 largest cities in the US, there's not even one city where whites live in ecological equality to blacks in terms of poverty rates or rates of single-parent households. The worst urban context in which whites reside is considerably better than the average context of black communities. Economic policy is health policy. In the last 60 years, black-white differences in health have narrowed and widened with black-white differences in income. Essentially, for what this says, when a man or a woman grows up to be a commercial sex worker, or an individual becomes homeless, no one grows up wanting to be homeless or be a commercial sex worker. Something happened. Society failed. There's something we did not do the day before, right? It's like you become HIV positive and then you have all these services. Food and nutrition services, you get housing, you get a car, you get a car, you get a car, you get a car, right? What happened to the day before you got infected and became positive? What did we not do to help that person? But if you empower the individual, and this is what the slide is saying, give the person a job, they'd rather that. They'd rather go work and make money than be a prostitute and sell drugs and all those other stuff, all right? Something to keep in mind. So the health effects of civil rights, policies narrowed black and white, the economic gap. The gains were greater for women than men. Black women had larger gains in life expectancy during 1965, 1974 than other groups. Between 1968 and 1978, black males and females aged 35 to 74 had larger absolute and relative declines in mortality than whites. Black women born between 1967 and 69 had lower risk factor rates as adults and were less likely to have infants with low birth weight and low APGAR scores than those born between 1961 and 63. And desegregation of southern hospitals enabled 5,000 to 7,000 additional black babies to survive infancy between 1965 to 1975. That is what ACA is also trying to do. So, shifting focus, and time is going, but I'm going to keep talking. Talk about the health disparities in HIV, viral hepatitis, STDs, and TB. Race and ethnicity. African Americans are 8 times, and Latinos are 3 times more likely to have HIV than whites. In 2013, African Americans had 12 times the reported gonorrhea rates of whites. Asian and Pacific Islanders make up less than 5% of the total US population, but account for more than 50% of Americans living with chronic hepatitis B. In 2014, Asians had the highest TB case rate, which was nearly 30 times higher than the case rates for whites and 3 times higher for those of African Americans or Hispanics. Gay, bisexual, and other men who have sex with men account for 63% of new HIV infections and are the only group in which HIV incidence is rising. They have 40 times more likely to have HIV or syphilis than any other men and account for 15 to 25% of all new hepatitis B infections. For LGBT youth, they have increased health risk behaviors, so injury, violence, suicide, tobacco, alcohol, sexual behavior, diet, physical activity. Lifetime risk of HIV infection among men who have sex with men. If current trends continue, half of today's young black men who have sex with men will have HIV by age 35. Half of all men who have sex with men will have HIV by age 50 if current rates continue. Where you live matters. Geography is important. 46% of all adults and adolescents with HIV live in 4 states: California, Texas, Florida, and New York. 9 states and Washington, D.C. reported a TB case rate above 3 per 100,000 population. These areas accounted for 57% of the national total. Where you live affects the health you get, the health care you get. Age. If you're young like me, and you're between 15 and 24 times 2, make up 27% of sexually active population, but 50% of the 20 million new sexually transmitted infections in the US. 1 in 4 new HIV infection occurs in youth aged 13 to 24. About 12,000 youth in 2010 were infected with HIV, and more than 75% of adults with hepatitis C are baby boomers, born between 1945 and 1965. Socioeconomic. If you look at socioeconomic status, it removes racial ethnic difference. HIV is not a problem of black people, right? It's a problem of poor people. The poorer you are, the more likely you are to be HIV infected. The more money you make, the less likely you are. The racial ethnic differences disappear based on income. So reducing health disparities and promoting health equity. So I referred to on the panel about the health impact pyramid. If you go down the pyramid, less individual effort. If you go up the pyramid, more individual effort. Things that affect the general population, I told you how education is important. You want more school. Education, housing, transportation, business affects everyone and gives a better health outcome. Changing the context to make individuals' default decisions healthy. If you go to school and the only thing on the menu is healthy lunch, you have no choice but to eat healthy, that fruit salad. But if you give me a fruit salad and you give me a hot dog and pizza, which one you think, if I'm 6, 7 years old, I'm going to eat? Right? I'm going to go for the pizza and the hot dog. Right? And when I go in here and eat lunch, guess what I'm going to go for? Because you put it in front of me. But if there's only a salad, I have no choice. But if you change the context, right? Long-lasting protective interventions require some effort. You have to go to the doctor to get a vaccine. But once you get the vaccine, you're good, right? Clinical interventions require more effort. And they're often done for things you can't even feel. So somebody tells me, hey, you have high blood pressure, you have high cholesterol. Take this pill every day for the rest of your life. Really? Right? How often, how compliant am I? Requires a lot of effort. We spend a lot of time doing education and counseling. We talk. And we think we say something to the patient. We see them every 6 months and they're supposed, because we're God, we say it and you're supposed to do it for the next 6 months until you come back and see me. And then we go, well, why don't you do what I told you to? Right? I say use a condom all the time. Each and every sexual act. But when I go home and I watch TV, it's like softcore porn every day, right? I tell you to eat healthy diets, and I watch TV and it tells me to supersize everything I eat, right? So we spend a lot of time on counseling and education. It's not that they don't serve a purpose. We don't do them frequent enough. The content of what we talk about is questionable at times, and it requires a lot of individual effort. So redefining health, 60 to 70% of health has seemingly nothing to do with health. We need to look at housing, employment, community development policies, income support, transportation, environment. So when we have meetings in these hospitals, people from those institutions should also be at the table. If I just tell you those things are important, oftentimes they're not there. And so you come back 10 years, you know, a mentor once told me when I just started off as a young professional, and he looked at my face and I was totally confused. And he said, don't worry about it. Come back 10 years, we'll be talking about the same things. True, because we really haven't addressed the root cause, the cause of the causes. So improving health, enhancing neighborhood and housing quality to improve health is important. So I'm in the National Center, my office is here. We have 5 divisions: HIV/AIDS prevention, STD, Division of Adolescent School Health, Division of HIV/AIDS prevention, Division of TB elimination, and the 3 of them have offices of health equity, and we contribute members to a health equity work group. We meet monthly, and we talk about research, policy, and programs that affect the nation. There are additional work groups that we participate in, and they're listed here. So, addressing health disparities is part of our national strategy. It has to be at the highest level of government for it to be important, right? It has to be there for leadership. Also, money has to follow it. You know, I know something is important to you is how much money you put towards the problem. Because you could say it, but here's $2. What I gonna do, right? Put money where it is. So it's in our strategic plan. Here's the goal. 1 is to decrease incidence of HIV, decrease incidence of infection, decrease morbidity and mortality, and decrease health disparities. It's a multi-tiered approach. Basic fundamental knowledge for all Americans, accurate information about HIV and sexually transmitted infections, for example. There's also community level and structural approaches in hardest hit geographic areas and populations, so widespread condom availability, social marketing for behavior change to foster supportive community norms, and then finally intensive individual interventions for those most at risk. So we talk about combination prevention. We're sort of done away with that. That's like doing everything, right? We say no, because combining interventions is not enough. All interventions are not effective. All effective interventions are not equal. So we've transitioned from combination prevention to something called high impact prevention, targeted and focused. So we've developed some metrics, and I've listed some of them here because, you know, oftentimes you come to work and you feel you're doing so much, But when you come back tomorrow, the problem is still there. So you're really effective at what you're doing? You know what I'm talking about, right? We've been doing this struggle for a very long time. And how far have we advanced? So it's important to measure what you're doing so you can make changes as you move along. So the next list of slides is some of the things that the agency is doing. So Health Department prevention funding, we have matching prevention funds to the HIV epidemic, about $360 million awarded to 68 health departments based on HIV prevalence. Geography is important, allows flexibility based on local epidemic modeling and needs, requires health departments to focus on interventions that will have the greatest impact on the epidemic, and jurisdictions must spend 75% of their budget on 4 key strategies through HIV testing, policy and structural interventions, and condom distribution. The expanded testing initiative, $102 million over 3 years, 25 jurisdictions. There were 2.8 million people were tested. About 18,400 persons were newly diagnosed with HIV. 70% were African American, 12% Latino. 3,381 HIV infections were averted. Recent funding awards targeting high-risk persons. New funding opportunity announcement will provide $185 million over 3 years for men who have sex with men and transgender persons, up to $125 million for health departments to increase PrEP. That's HIV pre-exposure prophylaxis to help prevent HIV infection, and using surveillance data to increase engagement in care. You know, when patients come to the clinic or the hospital, we collect all this information. We seemingly lock it into a vault and nobody ever sees it. We need to look at our data and ask questions and address the issues that come up. We have a lot of public health campaigns. You've all been on the buses and on the trains, and we have posters, brochures, pamphlets, Act Against AIDS Leadership Initiative. It's important to keep the message in. People need to know that there is a problem. The squeaky wheel gets the most grease. So that's important to have those campaigns. The hepatitis B campaign, 1 out of 12 Asian Americans and Pacific Islanders has hepatitis B infection, and an estimated 2/3 do not know they're infected. There's the No More Hepatitis B campaign launched in 2013, and it's the first national multilingual, multi-year hepatitis B communications campaign aimed at Asian Americans and Pacific Islanders. We're boosting hepatitis B prevention funding, awarded to 32 organizations to expand testing for hepatitis B and C, and linkage to care, treatment, and prevention. It includes funds for testing those at higher risk for hepatitis B and linking to care. Addressing TB inequities. So TB is a problem in 2 groups. We've done really well at almost eliminating TB. TB is a problem in homeless populations and foreign-born populations. So we need to increase our services for those 2 groups. And Brooklyn has a lot of foreign-born folks. Keep that in mind. CAPAS, Care and Prevention in the United States, $45 million over 3 years. Eligibility for funding limited to 18 states with the highest HIV burden. Among African Americans and Latinos and high AIDS diagnosis rates, you see the states. The focus on original ethnic minorities with HIV, with increased proportion diagnosed, overcome social and economic obstacles, social determinants of health, and work towards suppressed viral load for all. Don't forget about the schools. Everything starts with education. So the Division of Adolescent School Health has a funding opportunity announcement aimed at states with the highest HIV burden and local school districts based on HIV STD burden, poverty level, and number of students. The funding opportunity announcement includes prevention for young men who have sex with men. School districts encouraged to provide safe and supportive environment for LGBT youth, and health risks measured via the Youth Risk Behavior Survey. So the last thing about what we do, STDs, the STD prevention funding opportunity announcement offers greater flexibility to programs to direct resources to areas based on local needs. And something we're particularly proud of is the development of an HIV/STI curriculum for historically Black colleges and universities for medical schools. Doctors really suck at taking a sexual history. Right? Nurses are way better. We're uncomfortable, very uncomfortable. And medical school teach you about the disease, but they don't teach you about how to talk to people about very sensitive issues. So we're hoping to do better at that by development of this curriculum. So we have a lot of documents. We release policy documents about how to achieve health equity. We have a white paper commitments about the things that we're gonna do, and I'm going quickly because I know lunch is sitting out there. We have a lot of consultations where we bring really smart people like yourself to the agency and ask you, what are we doing right, what are we doing wrong, where should we go and move forward? More policy documents, the public health reports, 3 special issues that talk about social determinants of health. And substantial health disparities with HIV, viral hepatitis, STDs, and TB. Reducing disparities and promoting health equity is a top explicit goal for NCHHSDP. There's need for specific indicators and targets. We need more partnerships, workforce developments, and champions. And maximizing reductions in disparities requires careful modeling, targeting distribution of resources, and thoughtful individual, community, and societal level interventions. Thank you, and thank the patients, those infected and affected. Thank you for this invitation and all the gifts that I got in the lunch I'm supposed to eat. Of course, I would thank my agency with my work for to help my fellow citizens, the fellow panelists, and Dr. David Williams, who's a sociologist at Harvard. Many of the introductory slides that I gave are his, essentially. And thank you so much.
That concludes our 2016 Dr. Martin Luther King Jr. Leadership Award. We want to thank Dr. Duffs again for accepting the award and coming all the way up from the CDC. Thank our panel members. Thank the Vice Chancellor for coming all the way down to Albany to give us some greetings.